This is one of the hot topics for this year in St. Gallen because this is very complex. We are in a kind of axillary chaos after the publication of many trials with great data, and I will try to find in my presentation that we can integrate all this data in a logical way to our practice, to our daily practice. So the omission of axillary dissection and the omission of sentinel node biopsy are part of a de-escalation of axillary surgery that we are in. We had the publications of two important trials in the past 2 years about the omission of sentinel node biopsy. One was the SOUND trial, and the other was the INSEMA trial, both with the same results for T1 and 0 patients, clinically negative, ultrasound negative, and in these patients we can maybe in postmenopausal setting avoid or spare sentinel node biopsy, which is something that, of course, we have less side effects than the axillary dissection, but it's not with no side effects, and with a higher cost than axillary ultrasound. So it's better to go, in this case, to axillary ultrasound. And also when we have positive sentinel nodes, 1 or 2 positive sentinel nodes, we have the publication of another trial, the SENOMAC trial in April 2024, showing that we can spare axillary lymph node dissection even for mastectomy patients or for extranodal disease. So I think that the 2 past years, 2003 and 2004, were the axillary years.